Today is all about non-insulin diabetic medications. Welcome to the 6th video of the Inpatient Diabetes Management series. A link to the previous videos is provided below. Before we start, remember to sign up using the link below for PDF summaries of this video and future videos on our channel. In this video, we will discuss the following: a quick run of the available non-insulin diabetic medications, general guidelines about holding versus resuming these medications on admission. We will discuss incretin hormones medications, secretogoids versus non-secretogoids, choice of therapy in type 2 diabetes, medications with cardiovascular benefits, medications with benefits in chronic kidney disease, medications with weight loss benefits, medications that are safe to use during pregnancy, and we will finish with clinically important facts about non-insulin diabetic medications. Watch to the end. This video is full of clinically oriented information, and I promise you won't struggle to remember these medications in clinical practice or even answer any board related questions about them after watching this video. Let's start. All non-insulin diabetic medications are used exclusively for the treatment of type 2 diabetes, and they function by promoting insulin secretion as in sulfonylureas and meglitinides, improving sensitivity to insulin as in the TZD family or the glitazone family because they end with glitazone, or by decreasing hepatic glucose output as in metformin, or by delaying the delivery and absorption of carbohydrates from the gastrointestinal tract as in the Sgl2 receptors agonists, the Glucosidase family, and the DPP4 Inhibitors, the Gliptin family, or by increasing urinary glucose excretions as in Sgl2 Inhibitors, the Liflozin family, or by preventing intestinal glucose absorption as in the alpha glucosidase inhibitors, the BOZ family. All non-insulin diabetic medications should be suspended if NPO status, critically ill patients with critical hyperglycemia where insulin should be used instead, or the presence of a specific drug contraindication. Otherwise, these medications can be resumed, but unfortunately, most of them are not on the hospital's formulary list given their price tag, except of course metformin, some sulfonylureas, and I believe the Sitagliptin or Januvia from the DPP4 Inhibitors family is available in some hospitals. So use your clinical judgment on whether to resume or hold these medications. A diabetic patient who is acutely sick with pneumonia, for example, likely will have a poor or at least unpredictable oral intake compared to, for example, a diabetic patient who underwent a total knee replacement and is tolerating his diet with adequate oral intake. Remember, patients likely will improve clinically during their hospital stay and may be able to resume all or some of their home non-insulin diabetic medications. And patients should resume their medications on discharge if no specific contraindications and as long as their oral intake is adequate. Incretin hormones, which include the GLP-1 glucagon-like peptide 1 and the GIP glucose-dependent insulinotropic polypeptide, are secreted from the small intestine in response to food or eating. When we eat, incretin hormones are released, and when released, they function on three sites: pancreas, stomach, and brain. In the stomach, they slow down the emptying of food into the intestine, and in the brain, they suppress our appetite so we eventually stop eating. And in the pancreas, incretin hormones inform the pancreas about the incoming food, so it pumps insulin into the blood in response to food and reduce or inhibits glucagon production. Basically, incretin hormones coordinate pancreas insulin secretions with food intake. Incretin hormones are only stimulated by nutrition coming through our gastrointestinal tract, so IV dextrose or TPN, total parenteral nutrition, do not stimulate incretin hormone secretions. Now, this process is messed up in patients with type 2 diabetes. GLP-1 receptor agonists, the Glucosidase family, and DPP4 inhibitors, the Gliptin family, are two classes of medication that work to restore these effects, and we'll come to that soon. And now this is a perfect time to differentiate between secretogoids and non-secretogoids. Secretogoids, I hope I'm saying it correct, are medications that promote insulin secretion from the pancreas regardless of food intake. So whether you eat or not, these medications will promote insulin production or secretion, which puts the patient at the risk of hypoglycemia. Sulfonylureas and meglitinides belong to this group. Non-secretogoids, on the other hand, are medications that either do not function in the pancreas, so they do not promote insulin secretions. Metformin, Sgl2 inhibitors, alpha-glucosidase inhibitors, and the TZDs families belong to this type, or medications that still promote insulin secretion from the pancreas but only in response to food. Medications that potentiate incretin hormones function like GLP-1 receptor agonists, the glutide family, and DPP4 inhibitors, the gliptin families, belong here. But hold a sec, didn't we say secretogoids promote insulin secretions? Yes, so why do the incretin hormones potentiators like GLP-1 receptor agonists, the glutide family, and DPP4 inhibitors, the gliptin family, not considered secretogoids? Simply because they promote insulin secretion again in response to food, while secretogoids promote insulin secretion regardless of food intake. Non-secretogoids do not cause hypoglycemia unless combined with the secretogoids or taken in conditions that precipitate hypoglycemia like critical illness, liver disease, adrenal insufficiency, NPO status, etc. In general, non-secretogoids are preferred over secretogoids for type 2 diabetes treatment. And among the non-secretogoids, metformin remains the first line in type 2 diabetes treatment. Sgl2 inhibitors, the liflozin family, GLP-1 receptor agonists, the glutide family, and DPP4 inhibitors, the gliptin families, come next. Alpha-glucosidase inhibitors, the BOS family, are not widely used because of relatively low efficacy, poor tolerance, and their cost. The TZD family use had dramatically decreased because of the association with heart failure and weight gain. If used, it's usually pioglitazone, and I will talk about this later in this video. Secretogoids, especially sulfonylureas, remain a good alternative when non-secretogoids cannot be used because of a contraindication, affordability issue, or inadequate control with non-secretogoids, and the patient does not like to start insulin therapy. Basically, we are shifting away from secretogoids. So what's special about GLP-1 receptor agonists, the glutide family, the Sgl2 inhibitors, the liflozin family, and DPP4 inhibitors, the gliptin families, to come next after metformin? That brings me to the medications with cardiovascular mortality benefits. GLP-1 receptors agonists, the glutide family, Sgl2 inhibitors, the liflozin family, hopefully these names will stick in your mind, are associated with a decrease in overall mortality in people with diabetes and established cardiovascular disease. The Sgl2 inhibitors, the liflozin family, appear to decrease mortality even in those without established cardiovascular disease but with multiple cardiovascular risk factors. DPP4 inhibitors, the gliptin family, do not have any cardiovascular mortality benefit. Now, how about mortality benefits in heart failure? The liflozin family, Sgl2 inhibitors, reduce mortality in heart failure with reduced ejection fraction, and now they are considered part of the heart failure with reduced ejection fraction guided therapy, even in the absence of diabetes. In heart failure with preserved ejection fraction, they appear to reduce the risk of heart failure morbidity like hospitalization and improve quality of life, but did not clearly reduce the risk of mortality. Sgl2 inhibitors, the liflozin family, remember this name, do not stop there even. They also reduce the progression of diabetic kidney disease. GLP-1 receptor agonists, the glutide family, and DPP4 inhibitors, the gliptin family, have no benefits in heart failure or chronic kidney disease. Now, how about weight loss? GLP-1 receptor agonists, the glutide family, Sgl2 inhibitors, the liflozin family, and metformin are all associated with weight loss, especially GLP-1 receptor agonists, the glutide family. Particularly Semaglutide, the brand name is Ozempic, and Liraglutide, the brand name is Victoza. DPP4 inhibitors, the gliptin family, are weight neutral. They do not cause weight gain or weight loss. Now, given all these benefits with GLP-1 receptor agonists, the glutide family, and Sgl2 inhibitors, the liflozin family, these agents are next to add after metformin, and I believe it's a matter of time until you see Sgl2 inhibitors, the liflozin family, and GLP-1 receptor agonists being used in most diabetic patients because of these benefits. But hold on, so we are saying DPP4 inhibitors, the gliptin family, are weight neutral and have no benefits in cardiovascular disease or chronic kidney disease. So why they are preferred over the TZDs family and alpha glucosidase inhibitors? Simply because they are more tolerable than alpha glucosidase inhibitors and have a better safety profile than the TZD family. Pregnancy, metformin and glyburide are the only non-insulin anti-hyperglycemic drugs that are safe to be used in pregnancy. Remember that insulin-based therapy is still the preferred therapy in pregnancy, but these oral agents can be used if insulin cannot be used for any reason. Also, they may be used along with insulin if needed. Now let's go over some important clinical facts of each class of these non-insulin diabetic medications. By the way, if you're enjoying this video so far, I would love it if you give us thumbs up. Apparently, it really helps with the YouTube algorithm. Let's start with metformin. As we mentioned earlier, it remains the first line treatment for type 2 diabetes and probably the most widely used non-insulin diabetic medications. It comes in oral forms only, and remember that it is along with the GLP-1 receptor agonist, the glutide family, and Sgl2 inhibitors, the liflozin family, associated with weight loss. In clinical practice, it is used in diabetes prevention in pre-diabetic patients, type 2 diabetes management, gestational diabetes if insulin cannot be used or along with insulin, and to induce ovulation in polycystic ovary syndrome. Gastrointestinal adverse reactions including diarrhea, nausea, flatulence, dyspepsia, vomiting, and abdominal pain are the most commonly reported adverse reactions to metformin use. These symptoms are usually mild, transient, and reversible after dose reduction or discontinuation of the drug. Symptoms can be mitigated by starting at a low dose with slow dose escalation as needed. Give me your full attention here, please. Avoid metformin in the presence of lactic acidosis or any condition that predisposes to lactic acidosis, such as volume depletion state, whether a true volume loss like vomiting, diarrhea, bleeding, sepsis, or decreased effective circulatory volume like in CHF exacerbations, hypotension whether with or without a shock, severe hepatic impairment, remember lactate gets metabolized in the liver, and contrast exposure within 48 hours. This may change in the future given that we have safer contrast agents nowadays. So if any doubt your patient may have hypoperfusion and lactic acidosis issue, just hold metformin. Also hold metformin if the GFR is less than 30 or if any worsening in kidney function, and pay attention here, we look at the GFR, not creatinine clearance. One more thing, and this is for the boards. The long-term use of metformin may lead to B12 deficiency. Let's move to the Sgl2 inhibitors, sodium glucose cotransporter-2 inhibitors, or the liflozin family, Empagliflozin, Dapagliflozin, Canagliflozin, etc. As we mentioned earlier, they are the only class that function in the kidney by promoting glucose urine excretions. In clinical practice, Sgl2 inhibitors have been associated with the following: normoglycemic DKA and hypotension. Very important to remember this. So if a patient who is on the liflozin agent presents with nausea, vomiting, and abdominal pain, check their anion gap and ketones even if their blood sugar less than 250. Patient, if this proven to be secondary to Sgl2 inhibitors, patient should be taken off Sgl2 inhibitors indefinitely. That's why Sgl2 inhibitors are contraindicated to be used in patients with a history of previous DKA, and if a patient who is on the liflozin family present with dizziness, lightheadedness, or syncope, check their orthostatic vital signs. They may have Sgl2 induced hypotension. Sgl2 inhibitors modestly decrease blood pressure. If confirmed, again, Sgl2 inhibitors or the liflozin family should be suspended until hypotension is resolved, and other blood pressure medication may need to be adjusted as well. Because Sgl2 inhibitors work on the kidney, we should avoid using them if the GFR less than 30. Unless they are used for diabetic kidney disease, then we can use them as long as the GFR above 20. Let's move to GLP-1 receptor agonists, the glutide family, Dulaglutide, Exenatide, extended release and instant release, Semaglutide, Ozempic, Liraglutide, Victoza. All these are given sub-Q except Semaglutide, which can be given orally and sub-Q. They function by potentiating the effect of incretin hormone, the GLP-1, as we mentioned earlier. Tirzepatide is special here, is unique because it is dual GLP-1 and GIP receptor agonist. Nausea, vomiting, diarrhea are prominent side effects of this class and can be severe and lead to severe cases of acute kidney injury requiring dialysis. Acute pancreatitis and acute cholecystitis have been associated with their use, so keep them in your differential when a patient presents with abdominal pain, nausea, vomiting, and diarrhea. They should be immediately suspended until proven otherwise. Keep in mind they are contraindicated in patients with a personal or family history of medullary thyroid cancer or in patients with multiple endocrine neoplasia syndrome type 2, MIN2, as they may increase the incidence of medullary thyroid cancer. Let's move to the DPP4 inhibitors, Dipeptidyl peptidase 4 inhibitors, or the gliptin family. Sitagliptin, Januvia, saxagliptin, linagliptin, and alogliptin. They function by potentiating the effect of incretin hormones by preventing their degradation. So they are kinda cousins of the glutide families. They are taken orally compared to the GLP-1 receptor agonists, which are mainly taken sub-Q. Similar to GLP-1 receptor agonists, they can also cause GI symptoms, acute pancreatitis, and acute cholecystitis. And remember, this DPP4 inhibitors, the gliptin family, are notorious for causing flu-like symptoms. Let's move to the alpha-glucosidase inhibitors, or the BOZ family, acarbose, miglitol, and voglibose. I'm not sure how often you will see them in practice. They are not widely used because of the relatively low efficacy and poor tolerance. They work by inhibiting the upper gastrointestinal enzyme, the alpha-glucosidases, that converts complex polysaccharides carbohydrates into monosaccharides, and thereby slowing the absorption of glucose and reducing postprandial blood glucose concentrations. They are not available in hospital formularies, so don't worry about them, just hold them in admission if it happens you encounter a patient who is taking them. And remember, if a patient becomes hypoglycemic while taking the alpha-glucosidase inhibitors, and remember they are part of non-secretogoids and they do not cause hypoglycemia by themselves, but hypoglycemia still may develop if combined with a secretogoid or if taken in the setting of a condition that precipitates hypoglycemia, as we explained earlier. So if hypoglycemia develops while on alpha-glucosidase inhibitors, only pure glucose tablets should be used to reverse hypoglycemia. Other forms of carbohydrates are less effective in raising blood sugar value given how this class works. Let's move to the last class in the non-secretogoids, the TZD family or the glitazone family. I cannot say their long name. They work by increasing insulin sensitivity by acting on adipose tissue, muscle, and to a lesser extent liver to increase glucose utilization and decrease glucose production. Rosiglitazone and pioglitazone are still available in the USA. I doubt you will see rosiglitazone being used anymore. Pioglitazone may still have some clinical uses, particularly in diabetic patients with biopsy-proven non-alcoholic steatohepatitis or NASH. Pioglitazone improves fibrosis as well as inflammation and steatosis in such patients. The TZDs family should be avoided if there is heart failure or any evidence of fluid overload, history of fracture or at high risk of fracture, example like postmenopausal women with low bone mass, active liver disease, liver transaminases more than 2.5 times above the upper reference limit, unless NASH is known to be the underlying cause of the increased LFTs. Or of course avoid TZDs if there is active or history of bladder cancer, and of course avoid them in pregnancy. Finally, time to move to the secretogoids family. This group includes sulfonylureas and meglitinides, and as we mentioned earlier, this group promotes insulin secretion regardless of food intake and can cause hypoglycemia. Let's start with sulfonylureas: glipizide, gliclazide, glimepiride, and glypiride. And remember, gliclazide is not available in the USA. Glipizide and glimepiride are short-acting and safer to use in diabetics with chronic kidney disease who are not dialysis dependent yet. Glyburide is safe in pregnancy, as we mentioned earlier, and can be used in gestational diabetes. Sulfonylureas have no cross-reactivity with other sulfas, including sulfa antibiotics. Sulfonylureas remain good alternatives if other agents like metformin, Sgl2 inhibitors, GLP-1 receptor agonists, DPP4 inhibitors cannot be used for any reason or are inadequate and the patient does not prefer insulin-based therapy. Let's finish with meglitinides. Mainly we talk about repaglinides, which again is another class that I don't recall when was the last time I saw a patient who was on a meglitinide. But they still can be an option if a patient cannot use sulfonylureas because they are allergic to, for example. In the end, I hope you are one of the very few who usually finish a video. If you find it useful, make sure to hit the like button and share it with your colleagues. In the next video, I will discuss the insulin sliding scale in clinical practice. Thanks for watching and see you soon.